preoperative planning is really important if that can occur. And so making sure that they're staying on their substance use disorder medication, such as methadone or Subutex, is very important. We don't want the patient to stop taking those medications. That's important for them to maintain on. The Once they're for the procedure, there are things that we can give preoperatively, such as gabapentin or ketamine and Tylenol. We can actually give those before the procedure. And those multifaceted medication approaches, the multimodal, we call it, is the best approach for them. In addition, in our spinal and epidural, we do provide the long-acting opioid, which is called Duramorph, which is a morphine derivative. And if the patient's allergic to Duramorph, we can actually use hydromorphone or Dilaudid as well. In addition to a short-acting opioid such as fentanyl, we can add to it to optimize that spinal or epidural. Post-operatively, it's really important to have a post-operative plan. So in these patients, we like to provide tap blocks, and those blocks are important because it actually numbs the abdominal area that the cesarean delivery is in. If the OBGYN doesn't have an anesthesia provider that could provide a tap block, the OBGYN provider themselves could just inject local into the subcutaneous tissue. The other thing that's important is to start them on multimodal analgesia immediately after the surgery. And that looks like a combination of Tylenol and ibuprofen. So the Tylenol we've given preoperatively, and then 8 hours after that, you would want to start with another dose, usually 975 milligrams to 1,000 milligrams. And you want to continue that every 8 hours for up to 72 hours. And non-steroidals, if the patient doesn't have a contraindication to non-steroidals, the anesthesia provider can give ketorolac at the end of the procedure. And then again, 8 hours later, they should start with oral ibuprofen at a dose of 400 milligrams and give that every 8 hours. It's really important to continue those. A patient with substance use disorder and chronic pain or a chronic pain history, they may in addition need oxycodone for rescue, or they may even need a PCA, where a patient-controlled analgesia. The tap blocks that I mentioned last about 12 hours. Those can be repeated the next day. So if a patient could have a repetitive tap block, and I've done that, where they got one immediately post-operatively, and then the following morning we provided them another one. So those patients, the proactive planning is really helpful. And if they have an emergency cesarean delivery, I still think many of those avenues that we talked about post-operatively, you could still incorporate into your plan.